Well, welcome and hello to everybody. I'm Emanuele D'Antonio. I'm the director of the BTIU in Health and Genomics, and I'm very pleased to welcome Professor Dave Roberts and Dr. Lise Estcourt for this BTIU seminar. So I'm sort of really excited about this seminar. This is in relation to NHSBT strategy about convalescent plasma study, and this is one of the hot topic I think that came around after the pandemic started. And so I'll leave the floor to Dave and Lise. I think you're now well used to all this web seminar. I think please mute yourself, and then we have time at the end for question. We have the chat box for asking question, and then we'll manage that through either a live question or I read through the chat box. So, well, Dave, please, up to you.
Okay, Emmanuel, thank you very much, and the BTIU for inviting us both. It's a real pleasure to talk about this. It's been a great initiative on behalf of the DHSC and NHSBT. I'm going to tell you just a little bit about how we came to do it, the operational challenges we faced as we've scaled up collection for what is an entirely new process for a new product for a new disease, and then hand over to Lise, who's going to tell you a bit about how we've deployed that new product and what the implications are for the future. So I'm just going to start screen sharing now. Okay, can you see that? Is that okay? Right. So I'm just going to tell you a little bit about what convalescent plasma is, why it was thought it might be useful for this disease, tell you a little bit about how we've defined what plasma we should use, and then spend some time about how we've collected it and give you some idea of the scale and complexity of that, which has drawn in over 500 new people to what has really been to create a new division of NHSBT with a budget within the year of about £100 million. So almost adding on another limb to NHSBT. And then Lisa's going to tell us the important stuff about what we're actually going to do with it. And I hope we can, at the end, reflect on future prospects, because this is a new therapy. There's no guarantee, of course, it will work. And we're going to reflect on, even if it does work, about the complexities and challenge that may provide, and indeed what we might have to do in the future. So convalescent plasma, which is also called immune plasma, is plasma donated from people who've recovered from an illness. It contains antibodies to the pathogen. For it to be useful, it's got to contain neutralizing antibodies of sufficient titer to provide passive immunity to the recipient. It may be fractionated to produce purified hyperimmune globulin, and that's been used in several other illnesses. And Lisa's going to tell you a bit more about the history of that. Well, why should we think that a systemic antibody treatment is useful for viral infection? The systematic reviews that have been done do suggest overall that if you combine the data, and this is inevitably a rather heterogeneous and messy analysis in some ways, shows that if you combine the data for H1N1, swine flu and SARS, there is evidence that convalescent plasma can reduce mortality of between 20 to 30%, quite considerably. There's less convincing evidence that convalescent plasma helped in the Ebola epidemic. There was no significant reduction in death, but it later turned out that many of the donors who were giving plasma in those very, I have to say, almost heroic trials were actually seronegative, and it may be that there would have been an effect had there been sufficient neutralizing antibody. So why then were there no convalescent plasma programs ready to go? I think the first point in the UK is that there was no plasma collection program. The second is that most countries did not have a plasma program ready to go because there isn't really sufficient high quality evidence. And when we started this work, there was always also some concern that there would be potential harm, or could be potential harm for donors from non-neutralizing antibody that could cause antibody dependent enhancement. And this can occur for almost every viral disease where there is actually insufficient antibody to kill the virus, but where antibody may help a virus enter a cell. So without good evidence for efficacy and safety, health services haven't invested in advance in coordinated collection, testing and manufacture of convalescent plasma, nor indeed had they prepared in the UK in many other ways for this potential pandemic. But we were asked very early in the epidemic in March, directly by the Cabinet Office and the Office of Life Sciences, would we consider starting a convalescent plasma program? And that provoked an immediate challenge. In previous epidemics, we had collected plasma from whole blood donors and provided some tens of units. It was clear from the scale of this epidemic, we would have to provide not tens, not hundreds, but thousands of units. It would require enormous effort. The business case was submitted within a week after having engaged Deloitte. And I'll tell you a bit more about, when you see some of the later slides, I think you'll understand the need for detailed and thorough and extensive project support to carry this sort of program out. So initial tranche of funding was agreed to scale up to about 5,000 donors a week. And we set about doing this really as quickly as we could, and immediately realized we would have to have several different work streams. And I've just highlighted, this was in the very first phase of the epidemic, the sort of major elements of the program that we had to do. So in terms of donor outreach, we had to acquire records from NHS Digital of all hospitalized patients with COVID, set up a web form, and later we've set up data flows to get information from pillars 3 and 4 of the government testing program. In terms of collection, we could repurpose some of our collection capacity for using apheresis machines that was used for platelets, but it was also clear we'd have to set up additional capacity. And within a few weeks, we've planned to open and did open 3 new centres in London. You may have seen some pictures of these at Stratford, also in Bexleyheath and Twickenham. When this started, we had no tests available. There was no criteria for what should be used. So we set about comparing a series of screening tests with the gold standard neutralizing antibody tests. I'm going to tell you a bit more about that. The manufacturing capability had to extend to the digital capacity to handle a new product digitally, and also to expand storage facilities. As the trial started, hospital trusts had to be able to use convalescent plasma, and Lise is going to tell you much more about that. But let's look at some of the data we got then, comparing on the x-axis here, neutralizing antibody titer with a Euroimmune, which is a fairly straightforward and actually not very sensitive, although that's useful in this regard, but not very sensitive anti-spike ELISA. The neutralizing antibodies were done by Maria Zambon, and spike ELISA, the first batches were done by Public Health at Porton Down. We'd really like to use all the plasmas in this area. I hope you can see my pointer, but those plasmas with a neutralizing antibody titer of over about 100. This is a rule of thumb derived from those initial studies and some of the trials in SARS. And if we were to take a cutoff of 10 or just under 10, we could qualify about 50 of the first 250 units, but by reducing the cutoff to 6, we felt we could increase the number of units available, because that would be important to be able to treat people, enough people, without sacrificing efficacy. Now, this is a very fine balancing act, and we'll see, perhaps as we consider the trials and perhaps some other evidence that's coming out, that we should really, obviously, we should aim to use as high a titer as we can, but it's a very fine balancing act with trying to provide enough plasma while still efficacy. And what we settled on was to take a level which had a reasonable level of plasma. You can see the mean TCID 50, that's the level at which there would be 50% inhibition of a live virus assay, of about 400, and even when diluted, that would provide reasonable amounts of neutralizing antibody. So how did things go? So by June, as the program just got going in the first 2 months, we had here collected about 3,000 units of plasma with 300 in stock. And you can see the sort of capacity that the system had built up in just a couple of months. The call center was able to handle 10,000s of calls. We'd been able to recruit hundreds of new staff and release thousands of units of plasma. The REMAP CAP trial had started, so up and running, a complete trial in a couple of months, and the recovery trial was just starting. As I mentioned, a lot of work around IT, and these seem quite small things to mention, but our previous release cycle was over a year, so to get things going in a couple of months required a huge effort. And behind the scenes, there was an enormous amount of effort in procurement just to secure additional machines and harnesses. That's the actual plastic software, the plastic bags and all the tubing. And much of this has had to be flown in from Vietnam. So you can see the sort of success, lots of public engagement. We've had a stream of publicity going on to let people know and to drive donors to register, to become involved, and it's really involved print, radio, and TV. But the program has a number of real challenges in providing high titer units. So let's just have a look at the attrition of donors. These are donors for convalescent plasma as they come through the different stages of our process. It turned out that those first few hundred units donors we looked at had very high, there was quite a high proportion of people who had high titer antibodies. And that was because most of the people tested at that time, if you remember, actually had to be in hospital to get a test. If you weren't able to be admitted, people said stay at home, and several colleagues suffered at home for several weeks, almost certainly with moderately severe COVID, didn't get tests. So the first assessment of the proportion of high titer donors was really based on quite sick patients. As testing rolled out, that proportion got less. And let's just look at the best case scenario. These are male donors with a proven positive test. There's an attrition through people not attending. Not everyone can be bled. You've got to have 2 really good veins to be bled. Only about a third of those units are high titer, and then some fail validation. If you go to female donors, the attrition is much higher. We know that's partly because few of them can be bled, but also few of them are high titer. Men generally get sicker, generally make antibodies. So these sort of figures, where only, if you take on average about 10 or 15% of people had high titer donations, we introduced a separate stream of collection, where instead of inviting people straight to collect and then test the unit, we had sampling on session to try and pick out for donation just these higher titer donors. But there were many other challenges. So I'm just going to highlight some of them here. And these are really driven by the epidemiology of the cohort, and the need to maintain whole blood collection. So you can see here in cases that a very long period, which we're all very grateful for, there weren't many infections at all. Now we're collecting 28 days after recovery, so perhaps 2 weeks after people get infected. So although these are the cases now, our collection program is still trying to recruit people who are infected at the beginning of in September, perhaps had a test at the beginning of October. At the same time, if we look over here, we see a great deal of heterogeneity. This is sort of everyday news, but the cases and therefore the potential donors are very focused in the northwest and in West Yorkshire, perhaps a bit in London, in Wales, very heterogeneous. So we've had to have the problem of moving capacity around the country flexibly, which has proved challenging. The other problem we've had is that here collections of whole blood have been limited. We've lost about 10% of capacity. Normally supply and demand is very, very finely balanced. So to lose 10% of capacity is really serious. That's due to increased social distancing on session. So you can't put as many beds on a venue. We've tried to get bigger venues, but that takes time. And there are shortages of staff as people return from, people either have to self-isolate, look after carers, or are sick themselves. So you can see there is an increase in donors, but it's very slow. Given the this sort of epidemic was predicted, the second wave, and early there was additional news from America that a very large safety study in a completely uncontrolled fashion of 30,000 units were given under their emergency use authorization, but mainly there is some efficacy data which gives a hint of the higher band and the higher titer giving efficacy in patients who are treated early, but it also suggested that the units were safe. So the steering group of the program suggested we expand, and a business case submitted in September for a further 80 million to open 40 new centres. So this is, if you just reflect, this is a sort of immense challenge. I think in the last 3 years, we've opened one new blood donation centre and thought endlessly about one in London. So within the last few months, we've opened or plan to open 17 centres. So you can see these are sort of challenges that we face. This is just looking backwards on some of these sort of KPIs that we look at today. You can see sample slots are steady. They're not increasing greatly. The fill rate, this is the number of people coming through, is now starting to pick up, but has been pretty low. The higher titer units, the proportion of units we're collecting as high titer have fallen, as I've described, as the initial number of people who were quite sick have been diluted out with people who were, fortunately for them, less well, but were less able to collect really high titer units. And the supply has been steady, but demand, as you know now, is going up. So where are we now? We've moved on to collect over nearly 10,000 units of high titer, which is enough to treat 5,000 people, so enough for the clinical trials. We've also collected quite a lot of medium and lower titer units, which could possibly be used for fractionation. And these are sort of updates that we're looking at each week. Opening, I'll tell you a bit more about site opening, getting trying to drive more folk to register on the web form. We've been faced with the problem that deferral rates have increased slightly. People have been slightly more wary of accepting people who've recovered from infection, looking at their heart rate, perhaps newer and less experienced staff. In order to really transform the program, we need to screen people much more effectively. So we've setting up a series of 3 pilots to do sample people at home, to sample people in pharmacies. Boots and Lloyds have allowed pharmacies to be used for sampling, and also from Netherlands and Germany, a postal service. So if what they will do is send out a kit, as Emanuele and your colleagues have done for track COVID, to send off a sample, and it will be tested using the same Euroimmune assay that we've been using in Germany. We're also working with ZOAP to see if we can use an algorithm based on a few symptoms, so we can drive, try and predict people who are seropositive and perhaps even people of higher titers. So to use all these to drive a much greater filtering of folk who come onto session, to increase not just the volume but also the proportion of higher titer units collected. One of the other changes we've been able to do is to enable high titer donors to return not every 14 days as is usual, but to every 7 days. And again, each of these changes, this has involved consideration of donor selection guidelines and so on. So how's this working out? This is the projection for an increase in capacity from about 3,000 up to 5,500 or so with the opening of new centres, and would expect this to carry on. But it's crucial, as I've said, that we don't just increase capacity but increase the proportion of higher titer units collected. So I'm just going to run through just a couple of slides to finish off here. You can see these are just slides taken from the regular weekly updates, and the real challenge we've got now of recruiting and training another 500 people. We need to make sure we've got enough people to train them, and we've compressed the whole program by doing a lot online. So as happens very often in times of crisis, you can see that this challenge we've faced has really driven a massive change in digital performance, in approach to change, in approach to training. And I'll just pick up here again the number of options to increase high titer units. I've told you that the real problem here, this is the sort of initiatives that are going on. Behind each one of these lies a small program of work and data. As I've mentioned, we're trying to segment donors to try and make sure we only invite people who are likely to have high titer. You can see some of the other things here. I'm not going to go through them all. We're going to try and have, as you would in any sales or marketing system, have make sure that our best call agents, our best people doing the callings target the high priority groups. We're trying to reduce deferral by having a greater integration of clinical support, and then a series of initiatives to make sure that once people come and they are high titer, that they come back, both by making sure they can book it easily and making it important, making sure they understand, and the staff indeed understand the importance of that. So I'm going to end there. This is one of our highest titer donors, who by coincidence happened to be a doctor at Great Ormond Street, and he had a pretty tough time, but he came out of it with a neutralizing antibody titer that was absolutely sky high, 1 in 3,000. So his donations could treat many people. So I'm going to pause there. I'm going to stop sharing for a minute and hand over to Lise, who's going to tell you a bit more about the clinical history and recent other experience and our own work in trials and giving this donor to patients. So I'm handing over. Stop sharing now. Over to you, Lise.
Sorry, I really on mute still. I'll just go and share my screen now. There we go. Can everyone see that?
Yep.
Yes.
Yep. Great. Okay, so as can be seen from this photo, convalescent plasma is a very old treatment. So actually the first Nobel Prize for medicine was won by Emil von Behring, who's shown in this photo, for his work on convalescent plasma from animals being given to people to treat diphtheria. And as Dave mentioned previously, it's been used from then on in infectious diseases that don't have other treatments available. So it was used in the influenza pandemic, and has been used more recently in SARS, and MERS and Ebola. Now, how it can be, how we think it works, we think most likely way of it working is it actually neutralizes the virus and stops the virus entering blood cells, but it also is thought that it may have an effect by potentiating antibody-mediated cytotoxicity and enhancing phagocytosis as well. What evidence have we got for the effectiveness of COVID convalescent plasma in COVID? So we've done a living systematic review within Cochrane, and due to the speed with which the data is coming out, this was only published about 2 weeks ago, but is now quite out of date. But I'll just give you the evidence that was synthesized within the systematic review, and then talk about some of the trials that have been published since then. So there's been a lot of studies published, so non-randomized studies and ones without a comparator or with a comparator. And all of those studies that have been assessed up to now within the Cochrane methodology have shown that they're at kind of critical risk of bias. So actually you can't say whether or not convalescent plasma is effective using that data. So the only data that we had initially was 2 small randomized controlled trials. One was from China and one was from the Netherlands. And because there's only 189 participants within these 2 randomized controlled trials, it actually shows that there was relatively little evidence of effectiveness, but it was suggesting there may be an effect in that mortality, the risk of death seemed to decrease, although the 95% confidence intervals overlapped one, and there looked as though there may be an improvement in clinical symptoms measured by the need for respiratory support after 15 or 30 days within a trial. But as I say, things are moving on very rapidly. So what about the more recent evidence? For safety, there's 17 studies that have assessed SAEs, and that includes non-randomized studies. Now, the majority of participants are from this one uncontrolled, non-randomized study that Dave mentioned, which is a Joiner 2020, and they included 20,000 participants where they looked at safety. And they reported SAEs within 4 hours of transfusion and then within 7 days post-transfusion. And we can see that the rate of serious adverse events is very low, so it's less than 1%. So this is why the convalescent plasma program was expanded, because the concerns about safety were allayed by this very large study, which is saying there wasn't any evidence of major serious adverse events over and above the risk of just giving plasma to a patient. And there was no indication that there was any evidence for antibody-dependent enhancement, although it's actually quite difficult to assess that, because usually that would be marked by just a deterioration in the patient. So we're hoping that more randomized controlled trials that have reported SAEs in both people who've received convalescent plasma and those who haven't can be assessed. So really, based on the systematic review evidence, we really don't know whether it's effective, but it looks as though it's not too harmful. So there's been a trial published in September of Chile, and this is a pre-peer review that looked at giving early versus late convalescent plasma. And it's a really small trial again, and it really wasn't powered sufficiently to detect a difference. So they were giving early CCP when their patients were randomised versus giving it if patients deteriorated. But actually those patients who deteriorated actually very quickly after enrolment in the study. So 13 out of the 30 delayed group received CCP within a median of 3 days from enrolment into the trial. So you're really not going to detect a difference in such a small trial, whether or not it makes any difference. The largest trial that's been published up to now is the PLACID trial, and this was a study that was based in India, and this was giving convalescent plasma as 2 units of 200 mils 24 hours apart. Now, they didn't actually pre-screen the plasma prior to giving it to patients who'd got COVID, and what's been found is actually when they screened it afterwards, only 70% of participants received at least one unit of CCP with actually any antibodies at all. So out of the 2 units given, only 1 of those had any detectable antibodies. And then when you look at neutralizing antibody levels, now Dave was mentioning for us in our studies, we have a median neutralizing antibody titer of kind of 1 in 250. And for them, we're only having about 28% of patients receiving 1 of the 2 units with neutralizing antibody level of 80 or above. So very, very low levels of antibody in the plasma that they were giving. So actually a large proportion of the transfusions they were giving didn't really contain any antibody. They didn't see any difference, but I don't think that's really surprising because of the low levels of antibody that was assessed within this trial. Then was a trial in Baghdad that looked at, they had detectable ELISA antibody levels, and they did show a difference between patients who'd received convalescent plasma and those who received standard care. So it suggested a decreased mortality. So 1 in 21 patients died in the convalescent plasma arm versus 8 out of 28 in the standard care arm. And also a decreased duration of severe disease from 8 days to 4 days. So, but these actually were patients who had been treated relatively late in the course of their disease. So the duration of infection prior to enrolment was 14 to 16 days. A Spanish trial that is now restarted. It was stopped early over the summer because of a lack of recruitment of participants, but now they've restarted the trial. So this is an interim analysis. And again, this showed a decrease in the risk of death and a decrease in progression. And although it's not statistically significant, all the kind of studies that have looked at or given convalescent plasma with higher levels of antibody have shown that there may be an effect with giving convalescent plasma. And the median antibody titer in the Spanish trial, was around 290. So it again shows that there may be an effect with convalescent plasma. Even putting all of these trials together, we don't see an overall effect yet in whether convalescent plasma decreases mortality. So therefore, we need to do bigger trials assessing the use of convalescent plasma in hospitalised patients and in ITU patients, and which is what the trials we're doing in the UK. So the REMAP-CAP trial is the ITU trial that we're doing in the UK and across multiple countries around the world. So we are doing this trial now in the UK, Australia, New Zealand, Canada, Ireland, and the US. And it's assessing the use of convalescent plasma in people who've been recently admitted to ITU. And it's comparing convalescent plasma versus standard care, but also patients can be randomized to other treatments. So on average, people are also randomized in other domains to at least one other treatment. So this could be antivirals, immune modulatory agents. We're planning to recruit up to around 2,000 participants, but it's a Bayesian analysis trial. So they're doing interim analyses, and the trial will stop when it's been shown to be effective. And we're also doing a subgroup analysis looking in great detail about the effect of convalescent plasma on viral load, antibody responses, and also looking at cytokine responses in up to about 400 participants. We've recruited, as of this morning, 509 participants within the UK, and there's about another 70 patients recruited worldwide. The recovery trial is the big trial, and this is the same trial that assessed the benefit of dexamethasone in patients with COVID. So we're working with this team to assess whether convalescent plasma is useful in any hospitalised patient, both children and adults. We're also now assessing against a monoclonal, so patients in certain hospitals can be randomised 1:1:1 against convalescent plasma, Regeneron, the monoclonal antibody, or standard care. And we're planning to recruit at least 5,000 participants. Now, recruitment in the recovery trial and REMAP-CAP is increased significantly. And so we're expecting to have randomised at least 3,000 participants by Wednesday. Again, both of these trials are also doing samples at baseline to assess antibody responses, and they will do subgroup analysis in recovery, assessing the effect of convalescent plasma according to the severity of illness of a patient, the time from first symptoms to time of treatment with convalescent plasma, and also looking about whether patients had antibodies detectable at baseline or not, to see whether if an effect is seen, is it an effect that's seen in all patients, a subgroup of patients like in steroids where it was seen with oxygen therapy or patients who are ventilated, or is it only those patients who don't have detectable antibodies at baseline, or a short period of time between the onset of symptoms and treatment. We're not the only people doing trials, so there's 91 ongoing convalescent plasma trials around the world at the moment. 15 trials are larger trials, so recruiting 500 or more participants, of which the recovery and REMAP-CAP are 2 of those 15 trials. So what happens? How quickly do we think we are going to finish these trials? Actually, a lot faster than we thought at the start of September. So all our predictions have changed. So it is likely that we will see an end of recruitment to recovery in December, because we should have sufficient patients to have an answer by November, and because the primary outcome of the recovery trial is 28-day mortality, it'll be another 4 weeks before the DSMB will assess whether there's sufficient data to stop or not. Again, with recovery, we're seeing a big increase in recruitment of currently around 40% increase week on week, and therefore we are likely to see at least 1,500 participants recruited by November, which means we should have an answer for both trials before the end of this year. Now, I think the concern we have then is that if we do have a trial that finishes before the end of December, and we are finding that it is beneficial in all patients, there'll be a major problem with supply, because we currently are only randomizing around 10% of participants to the trials. And if we found that convalescent plasma is useful in all patients, we'll have a huge increase in demand with only a kind of slow increase in supply. So this is a concern because we would run out of plasma and our kind of stock of plasma within a very short period of time. So we need to think about ways, and that's why we're doing a huge amount of work at the moment to try and increase our supply by increasing number of donor centres, finding various ways of recruiting donors, because we're concerned that if convalescent plasma is shown to be effective, then we'll have a huge amount of demand, and how do we cope with that? So post-trials, obviously we're going to synthesize the data. We are going to work with NICE on creating rapid C19 guidelines, and we're going to again continue updating the systematic review. We're also working with the Health Economic Research Centre in Oxford to look at who would benefit the most, even if it's shown to be beneficial in all, starting off with looking at the number of life years saved and then going on to use QALYs when that data is available, as REMAP-CAP is collecting quality of life data at 6 months within that trial. So we can use that to assess, but initially we'd need to use number of life years saved to assess which patient group would derive the most benefit from convalescent plasma of all those groups that are assessed. What about future work? Well, we're targeting convalescent plasma collection to increase the proportion of high titer donors, as Dave has said. We're working with partners in the EU to identify and develop use of convalescent plasma across Europe, and also developing guidance and kind of working out, again, further development of health economic work on use of convalescent plasma in this pandemic and potentially future pandemics. We're planning to do a third trial in high risk patients that are outpatients. And so that's looking at patients who are immunosuppressed either due to hematological malignancies, stem cell transplants, solid organ donations, or inherited immune deficiencies, and using convalescent plasma very early to see if that can prevent progression of disease in those patients that are unlikely to respond to a vaccine and also high risk of getting severe or fatal disease. We're also going to be looking at working with AstraZeneca or other monoclonal manufacturers to see if we can do potential 3-arm trial of convalescent plasma monoclonals or standard of care. So as you can see, there's been a huge amount of work since our programme launch, and we've had to adapt very rapidly to and change kind of the way NHSBT has worked in a dramatic way. You can see there's 2 large trials that are both kind of adaptive trials, and we're working with developing new guidance, systematic reviews, and working with NICE and NHS England to develop guidance and think about strategies if there's a restriction on the supply of convalescent plasma. This only kind of lists a few people that we should be acknowledging. There's kind of a huge team of people who've done a massive amount of work. And again, we're just kind of a plea for anyone to, if they are kind of have had COVID and could donate, that come forward and donate convalescent plasma to help with our supply. Thank you.
Thank you, Lise. That's great.
Well, thanks, Dave. Thanks, Lise. I think there's an incredible effort, huge effort from NHSBT, from you both as well. And it's very nice to listen to how actually the story evolved and how it's the challenges that we'll face over the coming months. Thanks a lot. Question from the floor. I'll start with one. So You mentioned, Dave, about donors being invited and sort of donating. How actually, there is evidence now that the antibody response is actually declining over time. How much actually donors are able to donate? How often actually, and for how long, donors are able to donate with enough titer that will make sort of usable plasma?
Well, that's a good question. We're kind of feeling our way. That obviously the higher you start, probably longer you go on. There are two other things. We've measured the decline in Euroimmune, which kind of goes from a 0 to 12 scale, and we're interested in the 6 to 12 range, and that declines by about 1. I mean, it's not a linear scale, but roughly averaging everyone out, people are declining by about 1 unit every 3 weeks. There are some little twists to it though, because the immunologists have a whole theory about how and evidence that antibodies actually become higher affinity over time, and it's possible the immune system retains small amounts of antigen on follicular dendritic cells. So every time the B cells come around and are re-stimulated, those that bind more those that bind have higher affinity are stimulated proportionately more. So we think antibodies do go down. I mean, the ballpark figure 6 to 9 months perhaps, but quite steadily. So you could drop out of that high titer zone quite quickly. We might get a slightly different picture when we look at the affinity of antibodies. So that's pretty much as regards reduction. So in terms of collection, we've had one person donated 10 times, and up to now they've only been able to come back 2 weeks. So they've stayed above that they've been able to donate for best part of 6 months. Now people are coming back. We would expect some of these donors quite regularly to give 5 or 6 donations over 1 or 2 months. So we're into new territory. We're really repurposed our whole collection program, so it's much easier for people to rebook. You would have thought it's incredibly easy to do, but it needs a whole lot of work in terms of sample grids and just the electronic facility to do so. But we hope a lot more people will be able to come back every week. So perhaps giving 3 or 4 donations, I guess, would be kind of average. So that will help us get around this sort of very, very small 10%, 20% of 10% of people who actually have high titer antibodies that we test. If each of those could give 3 or 4 times, we'd be in a much better place.
And as I see there's a question from John. If John, you want to read that out. In the meantime, please feel free to question in the chat so that if there's any other. John.
So thank you both. Lovely talk. Dave, could you expand on this trade-off and what the current evidence suggests is the way to maximize these limited dosages available, and how the science is going to clarify what the threshold is, if there is one? Well,
in an ideal world, John, I'd like to be able to tell you we have thought about it, but we were able to test several different bands of antibody. However, it was quite clear from the outset, given the speed and scale and of the problem and the ability of hospital blood banks to handle plasma, that we could only have one concentration of plasma. So what we plan to do in we're going to look at the neutralizing antibody by pseudotype virus, but also more simply by the Euroimmune level in every unit we've given, and then work backwards to develop a sort of composite neutralizing antibody titer for the 2 units that we've given. We are giving 2 units, so people will get have a reasonable chance of getting a higher titer by virtue of this, picking up one of the higher titer units. Now, unfortunately, that comparison is not randomized, so we will be able to do it is a post hoc analysis. We plan to do it, but it's not a randomized analysis of trying to find out if there is an effect, where that effect starts to drop off. we did. I think if we thought there was an unlimited amount of high titer donors, or a very, very high number of high titer donors and only a few patients, we would have probably set the bar a little bit higher. But we took it down below to the point where we thought we might see the effect tailing off, so we could, define a cutoff for efficacy. The danger, of course, is that you then dilute out the power of the study, so you don't see any effect at all. What the Americans have shown, and what's clear from perhaps snippets of information from other studies, is that it does seem that antibody therapy is more effective when given early, when there are no pre-existing antibodies. So what the physiology of giving, or the immunology of it, is really that you hope to damp the virus down before you set up this inflammatory pneumonia that causes reduced oxygen carrying capacity and then admission to ITU. So you've probably, by the time people get to ITU, they probably have antibodies, but they're not doing much good because the virus has already managed to grow to such an extent, and the body respond in such a way you get endothelial and alveolar inflammation. So we suspect, if we would do post-hoc analysis based on antibody titer, but also the antibody level in recipients, we've collected samples from all 6,000, or planned to from all 6,000 recipients, and we've got a small army of people running as we speak, just sorting them out. We're getting 200 or 300 a day. We will do antibody tests in those to see if you've got what the effect of pre-existing antibody is. My own hunch is that probably it is effective, but probably only in a small, people early on and given a really good dose. And I do think that the future is twofold. One is monoclonals, and they're coming on, but supply will be restricted. And as Lise mentioned, we are starting a third trial where we're going to plan to give convalescent plasma, or control convalescent plasma, and a combination of monoclonals, probably from whichever company, to be honest, gives us the stuff. But the government, the vaccine task force, who look after monoclonals for some historical reasons, are negotiating on our behalf to get that. We've got another idea, which is to take volunteers, probably medical students, but not necessarily, and vaccinate them with antibodies, with vaccines that produce very high levels of neutralizing antibody. I'm only joking about medical students, by the way. We know that in animals, that some of those vaccines which can present, for example, dodecahedral antigens, can, as it have, hang on, let me just show you this, because I was just looking it up now. Can you see my screen? Can you see the screen?
Yeah.
Yes, we can.
Okay, so people have made these dodecahedral molecules which display, you can put the receptor binding domain on those, so they may be great vaccines, but they also produce very high levels of antibody, and it's possible that we could boost, it wouldn't be impossible to get, perhaps 10,000 people vaccinated with really high levels of antibody who are willing to come every week, and that could provide hundreds of thousands of units per year. So that might be one way of using the system. So I'm trying to say, John, the analysis we've thought about, but it's pretty difficult. It will be a bit dirty. We hope it's shown an effect. If it doesn't, we will, we are thinking of other ways to use antibody-based therapy, if that's okay. Rather.
Thanks, Dave. Very, very informative. And I guess, Will, is it partially answer your question, or?
Oh. Yeah, I think Dave's answered the question. Yeah, thanks.
Sorry, Will, I didn't see that. But
that's okay. I just asked you a question about the possibility of using plasma from people who've had a vaccine. So I think you've answered.
Yeah, I mean, obviously the Oxford type vaccine, where they inject virus, or adenovirus, that's mainly T cell based vaccine. So the antibody titers are about 1 in 100, but these structural, if you like, vaccines, they're getting 1 in 1,000, 1 in 3,000 easily. So maybe that's something, maybe that's what we'll use. Or in time, I think monoclonals, if they're cheap enough, will produce therapy, because they're the effect, 3 grams of the Donald Trump dose, 4 grams of Regeneron, and that's equivalent perhaps to 100 times what our median antibody titer is. So they're very, very potent, but the total world capacity of generating monoclonals is now devoted to churning these out. So apparently the government have tried to buy 500,000 doses of something. They're kind of trading on this like the Chicago commodities market at the moment, but if the part of the reason the government have invested so heavily in this is that it's one thing that we can produce ourselves that may plug a gap for some people for a while. If you give enough early, it could well reduce mortality. So I did have, I think we will get the answers fairly soon, and I hope it's a good one. I suspect it will be, good in parts, but I don't think this is a panacea. I think it's been invested in because it's potentially good, because it's something we can do, and if it could reduce mortality by 10-15%, that's still very significant. So we'll see.
Well, excellent. Thanks again, Dave. Thanks, Lise. If there's no other question, well, thank you again for this really excellent and stimulating seminar. And hope to see you soon, sometimes in person.
Okay, thank you for inviting us.
Thanks a lot. Thanks for everybody attending. Thanks.
Bye.
Thank you.